Hi, thank you so much for inviting me. Just a little bit of background about myself in case you don't know me yet. I am Brazilian. I hold a bachelor degree in computer science from a public university in Brazil. And as Amina mentioned, during my undergrad, I had two opportunities um, internationally. One, I came to Canada for a research internship, and then after that, I studied abroad in the United States, where I could advance computer science training and also do some research. At that time, I knew that I wanted to be in academia, but similarly to many countries in the global south, there is not a lot of resources in Brazil to stay in academia. So I decided to give a try in industry, where I worked for 4 years as a software engineer. And during that time was when the implementation of the General Data Protection Regulation was becoming more enforced. Companies were getting some benefits if they were following the law, all those type of things. And that moment was pretty important to me because it was when I realized how it's important to consider data governance, data privacy, and data sovereignty. When I decided to quit industry, I applied for a master's degree that I then transferred for a PhD here at the University of Calgary. And my entire thesis was about developing methods that we can enable sites that don't have a lot of data to participate in the creation of AI solutions. And since then, I stayed in the same lab as a postdoc. So, one thing that we cannot deny is that AI came to stay. In everything that we do, there is some software, some app, something that it's being powered by AI. So even when you don't think that you are using AI, you are probably using just by recommendations of Netflix, for example. And the reason that AI became such a popular tool, it's because it can understand and analyze different types of data alone or even in combination. And sometimes these data are very complex, and it can analyze in a way that it can facilitate many solutions for different type of tasks. And we don't really realize how much we generate data in our daily lives. But if we think about healthcare, from the day that we are born throughout our lives, we will be generating data from simple surveys or prescriptions to more complex data such as imaging and even genetic. And all these data can then be used to create AI powered tools for diagnosis, for lesion delineation, to predict survival, or even to understand how a disease progress, just to name a couple of applications. I know that there is this widespread fear that then AI will replace humans and that we should be aware of this. But I think that in healthcare, this it's not what I envision. What I envision is that AI will become a tool in the toolkit for clinicians. So pretty much when a clinician needs a second opinion, he will have the chance to ask an AI system. And then, for example, here the clinician could ask, "Do you think this patient is sick?" The system can then say, well, I believe that there is 76% of a chance of this individual being sick. And here are the regions of the image that informed my decision. Then the clinician can agree. If that happens, then the clinician can refer that patient to a specialized clinic, which may expedite treatment, but he has the right to disagree. And that's totally fine. And in those cases, he can consult a colleague or request more exams to investigate further, which may end up delaying treatment. But one thing that is very important is to understand will always be the clinician, the human that will be giving the diagnosis or the final decision for a patient. And this is where I see great promise for AI because then we can accelerate and give more support in areas that we don't have a lot of specialized people to take care of the population. But for these systems to be really great in identifying who is healthy from who is sick, there is a big challenge, which we usually call the data challenge. Because these systems need to see several examples of how the disease manifests across different populations to really be useful for a clinician. And in healthcare, this is a more pronounced problem than in other sectors, because if we think about a hospital, it can help a lot of people and collect a lot of data. But there is a high chance that all the people are from that region, because hospitals usually they are like region wise. You go to the one that is near to your house, or to the one that is specialized on a very specific disease, or they have a couple of specialties that they attend at that location, which means that even if they have a lot of data in terms of quantity, it may lack the representativeness that it's needed to learn how the disease manifests across different groups. So the standard way that in healthcare people collaborate, since collaboration is imperative for developing AI, it's what we call centralized, which means that many healthcare centers they can share their data to create this big centralized repository. And that will not only increase then size, but also the representativeness of the data. And this is pretty much what many big studies have done, such as the Cancer Imaging Archive and the UK Biobank, to name a few. Once this centralized repository is available, then a researcher can use it to develop AI solutions. While this is a very effective way of increasing data size and to some extent representativeness, it is still very expensive to create this big repository. It's time consuming to coordinate all the paperwork that is necessary for all these sites to share data. It requires a lot of resources because you need to store this data. And to some extent, it's weak on the side of the data sharing regulations. And it can also still have a weak representation because very often these big databases are created by wealthy nations, which means that there is not a good coverage in the representation across different populations. Recently, an emerging alternative to the centralized construction of a database, it's the distributed learning approach, which the core idea here is that the data will never leave the site where it was acquired, and you can still collaborate with others, but now to train and develop the AI model. The common approach to do this, it's called federated learning. And in federated learning, all the sites that are interested in collaborating for this task, they will be responsible for training their local models. And then the researcher in charge of this project, for example, is at the server side. And then the researcher is responsible for combining all these locally trained models using an aggregation function. That is just a way of how can we better combine the knowledge that was locally trained. An alternative approach to this is the traveling model, which I proposed during my PhD. And the biggest difference between these two approaches is that the traveling model does not require any aggregation function. And instead of doing this training in parallel, it will train a model sequentially, kind of fine tuning the model at every time that it goes to a different site. The biggest benefit compared to the centralized learning that both of these approaches offer is that they are less expensive and they require less resource, since each site just needs to store their own data and train a model on a reduced amount of data. And they also comply with the data sharing regulation because no data is being shared at all. But each of them, they have different strength and weakness. The federated learning approach, because it trains in parallel, it requires that each site that wants to collaborate, they have enough data to train an AI model. And it also requires that all those sites also have representation of all the class of interest. So if we think about a disease classification task, pretty much it would require that these three sites here, they have, let's say, at least 20 samples of data and that they have representations of people that are healthy and people that are sick. Whereas the traveling model does not have any restriction in terms of dataset size and representation, and it can be even trained in the extreme case where each site only have one data point, this way being more inclusive. And in the community, there is this assumption that because federated learning is in parallel, it may be faster than the traveling model since we need to wait until the model is trained at one site to move to the next one. But there is not enough evidence that this is really true. So, given that to some extent their strength and weakness are kind of complementary, the strength of one kind of fulfill the weakness of the other, we had this idea to combine these two approaches to see if we can then boost performance and opens opportunity for health, digital health equity. To investigate our new approach, we used a Parkinson's disease case study. And what I want you to notice here is that in this database, we have several sites that provide very small number of training samples, many of them only healthy individuals. Some sites here, they will have both representations, but then also there is a difference in the proportion that each of those classes are represented. So this database provided us the ideal scenario to then simulate and assume some things for our analysis. So here we assume that the sites that have a lot of data, they are likely better resourced, therefore they can represent wealthy nations. Whereas sites that do not have a lot of data, they are likely less resourced, and in our study, they are representing sites from remote or underserved regions. One thing that is very important to highlight here again is that because of this considerable variation in the dataset size, class imbalance, and even class incompleteness, it's extremely hard to train the federated learning approach given those needs for enough data and enough representation. And here I can show you how the federated learning fails in this classification task using this database. So here we have three baselines that we will be comparing our new approach, and two of them are federated only, and we investigated two popular ways of aggregating those locally trained models, and we can see that the accuracy and the AUC, they are pretty much chance level. Because since many sites, they don't have enough data and enough representation of both classes, when you train these models locally, they will not be able to distinguish and to create a decision boundary for this task. So it's pretty much noise that you are combining for your final model. The traveling model, on the other hand, it's capable of learning this task because of the way that it's trained and the way that it does not restrict any dataset size and representation. And here we can see that the accuracy achieved is 70% and the AUC is 77%. Since the traveling model was the only distributed learning approach that can learn the task, we will be comparing the new approach only with this baseline moving forward. But how our new approach works then? So in this hybrid approach, which we called FedTM, we designed a two-stage training. So in the first phase, we will have a federated warm-up phase where the better resourced or larger sites will participate in the training because they fulfill the requirement to be able to train a federated learning approach. After that, that model will be refined then to a traveling model phase where all sites now participate. Of course, there are many parameters that we need to tune and to identify how to better combine these two approaches. And some of the things that we needed to consider were how do we aggregate these methods, for how many iterations we train this warm-up phase, what is the minimum amount of data that the larger sites need to have to participate in that training process, and for how many iterations then we will refine later on in the second phase. To help us through the analysis, we grounded our work in three main questions. And the first question was, if we combine these, if we propose this hybrid approach, can we boost performance? And the first thing that I want you to notice here in this figure is that accepted by this box, all of them are above the dashed line, which means that most of the combinations of all those hyperparameters improve performance. And the other thing that I want you to notice here is that when we use the aggregation function proposed by FedAverage and we perform 5 or 10 rounds of the warm-up phase, where the 7 largest site, which means that they have more than 40 data samples to contribute for training, participate, we achieved the highest performances. The second question that guided our approach was, does FedTM achieve fairer outcomes for the better resourced and the less resourced sites? And what you can see here in this next figure is that the panel B and C, the gap here, it's larger. So this means that these combinations of parameters are not really making this model fairer. So we will be focusing only on panel A. And panel A here we can see on the green is our baseline, the traveling model only. And what we can see is that it has a performance disparity of 8% between the larger and the smaller sites. But when we combine them using the FedTM approach, there is one setup that it's using the Fed average and warming up for 10 rounds on the 7 largest sites that generate fairer outcomes, which means that we achieve a more balanced misclassification rate for the larger and the smaller sites. And one thing that it's important to highlight here is that we are not adding any fairness specific objective to the optimization process. This is just a consequence of smartly combining the approaches. The third question, and in my opinion, the most important result of this paper that grounded this work was, does FedTM alleviate the training burden on smaller sites? And the first thing that I want to highlight here is that when we increase the number of warm-up rounds in the FedTM, we can see that we effectively reduce the number of iterations that we need on the refinement phase. Since the smaller sites only participate in the refinement phase, we are therefore able to alleviate the burden of the training for those smaller sites. However, it's very important to notice that it does not directly translate into a substantial reduction on the total training time required for the task, because the computational burden is shifted to the better resourced site during the federated learning warm-up phase, while not reducing the total training time can sound a little bit discouraging, it's important to remember that since the Fed warm-up phase, it's only performed on the likely better resourced sites, there is no consequence for the places that don't have a lot of resources. So it's still a beneficial combination. Of course, we were very happy when we saw that we would be able to alleviate the burden, but there was still the question, in the end of the day, is this all clinically applicable? And then we decided to analyze, just comparing the best setup for the FedTM with the traveling model using the balanced accuracy, sensitivity, specificity, precision, and F1 score to see if it had an improvement or at least no decreased performance when we combine this way. And here we can see that the FedTM achieved a consistent improvement of 3 to 4% across all metrics. When we look at the performance in average, it can still hide some disparities. Therefore, we perform the same analysis, but now stratifying by larger and smaller sites. And here, once again, we can see that the performance differences across those metrics, they remained within a 1 to 5% range, which suggests that then this combination can also be useful in a clinical settings. So the takeaway of this work is that the FedTM boosts performance and creates opportunity for digital health equity by allowing less resourced sites to contribute to AI development, integrating their unique data sets, and increasing the likelihood that the final model will be able to provide meaningful and relevant outcomes to their population. Recognizing less resource sites' limitations and promoting a more equitable distribution of the computational load by allowing them to participate less often in the training process, and also by reducing the misclassification disparities, which is especially crucial to minimize the risk of developing models that perpetuate existing health inequities. One thing that I like to think and that kind of guides my work in the field, I truly believe that technology is a powerful democratization force, but I think that to move the needle forward in having less disparities or at least not propagating already existing disparity in our society, we need to embrace the differences instead of silence them. And to understand that we need to develop systems that can take in consideration the context that each population live, to truly use AI as a tool that can improve healthcare access and treatment for everyone. Thank you very much for your attention, and I'm happy to take your questions. You can scan the QR code if you want to get the paper, the code, or just connect on LinkedIn.